Disorders by the chair of the technical committee, Steve Fisher, and myself. I'm the co-chair. Yeah, we're very proud to have Dr. Paul Kuijer with us today. He will present a webinar which is called Without Ergonomics, No Effective Work-Directed Care for Patients with Musculoskeletal Disorders. Paul is a good friend of mine. He's based in Amsterdam. I'm based in Haarlem, which is approximately 20 kilometers apart from each other. And I'll let Paul introduce himself. Please, Paul.
Yeah, thank you, Erwin. Thank you, Steve, and thank you all for participating. I hope you're doing fine. I'm working as a principal investigator and human movement specialist at the Department of Public and Occupational Health at the Amsterdam University Medical Centers. The University Medical Centers consist of 2 academic hospitals, both on one side of the Amstel River. The above one is the Academic Medical Center, that's where I'm sitting right now. And the other one at the other side of the Amstel is the VU Medical Center. And before we worked together in the University Medical Centers, our department was called Cornell Institute of Occupational Health. And I'll try to skip to the next slide. Yes, some numbers. I've got 17,000 colleagues here. We got more than 6,000 students. Yearly, we got more than 700,000 outpatient visits. We got 1,700 beds, and each year about 400 PhD theses are produced and defended. Well, and the Netherlands is a very tiny country. In the dot, that's the Netherlands, and I'm in Amsterdam, and currently it's winter time. Unfortunately, no snow and no ice on the canals. I was a bit curious. You can put it in the chat where you are around the world. So feel free to put in the chat your country, where you are, and I'll ask Erwin to give a short wrap up. So,
okay, I see John is in Amsterdam, Sonia in Maryland, United States, Hank in the Netherlands, Paul McCool in Toronto, Canada, Erik, the Netherlands, Michelle, Amsterdam, Susan Cox from Montreal. So there's a whole
bunch, yeah, and everybody can see the chat. Yeah,
Sweden.
So, great.
Nigeria.
Well, the goals of this session. First goal is to raise awareness about the importance of ergonomics to ensure work participation among workers who are being treated medically, operatively, and non-operatively for their musculoskeletal disorders. And the second goal is to give an example of an integrated care pathway, including workplace adaptations aimed at work participation among workers with end-stage osteoarthritis of the knee who receive surgery for a knee prosthesis. So I like to accomplish these goals by addressing the following 5 topics. Care as usual does not secure timely work participation. The second one is ergonomics as a piece of the puzzle in non-operative care. Surgery does not do the trick. The disease first approach and return to work. And finally, back at work after surgery. And I'll start, of course, with the first one. Yes, indeed. This slide is in Dutch, and it's the only slide in Dutch. And what it says, it's the extra days of sick leave per worker in the first column, or for the total workforce. in the Netherlands in the second column, and we've got about 9 million workers. And these are the extra days if a worker is in the opinion that he or she has got a work-related disease. So when looking at upper extremity disorders, low back pain, hip osteoarthritis, or knee osteoarthritis, what we can see is that for low back pain, there are an extra 18 days sick leave if a worker thinks, well, my low back pain is work-related, and that counts up for the Netherlands for more than 700,000 extra sick leave days annually. And this slide opened my eyes a couple of years ago, because in the Netherlands, everybody is entitled to have the same care. So there's no difference between work-related care or occupational disease care or non-work-related care. So in my conclusion, usual care does not seem good enough to secure timely return to work, especially not for workers who think, well, my disease or disorder is work-related. Well, there are, of course, several reasons why people prolong their sick leave, and probably one of them is the following topic: ergonomics as a piece of the puzzle in non-operative care. And I've got a question for you. What works best, option 1, 2, or 3, to secure timely return to work among sick-listed workers for 3 to 4 months due to chronic low back pain? Is it workplace adaptations? Is it adaptation in working hours, or an adaptation of job tasks? So which one of these 3 interventions works best for timely return to work among these complex, often chronic low back pain patients? You can put it in there. I'll look at Aaron. Chat 1, 2, or 3, or
Yeah, Mary Robbins says often a combination. But
you have to only address. Erwin, it is typical. I have experts, all present. You can only give a 1, 2, or 3. So put a 1, a 2, or a 3, and Erwin does the math, and he'll tell me what the score is, sort of.
Well, number 1 and 3 are the most popular ones. So we've got 4 3s and 3 1s now, if people need to choose. Many say, okay, it should be all 3, but if we have to choose 1 or 3.
Well, this is a great group of experts, I already heard. Hopefully I can teach them something, but well, the answers are based on this cohort study performed in 6 countries, more than 1,600 workers. The adaptation of job tasks results in a median return to work of 299 days. An adaptation in working hours results, and I have to put my screen, otherwise 270 days. And well, workplace adaptations, you already guessed, it's not, only in 206 days. So the winner is workplace adaptations to enhance return to work among workers who are chronically sick listed due to low back pain. And that brings me to the next topic. And I think Erwin already told me that some of you already gave an even better answer. So if you combine this workplace intervention with graded activity and integrated care management, in this case in the Netherlands by an occupational physician, we can even probably reduce it to less than 200 days. And this is one of my favorite all-time studies in occupational health, and I'm totally not involved. And this study by Lambeek shows that these 3 interventions combined will result in 88 days return to work. So integrated care, workplace intervention, and time contingent graded activity results in 88 days, and the care as usual in the Netherlands is about the same as the data I showed you in the former study. It's more than 200 days for return to work. So, ergonomics as a piece of the puzzle in non-operative care. Hopefully these two papers have proven my points, or at least supported my points. That brings me to the third topic. Surgery does not do the trick for return to work. And remarkably, the last years, more and more studies appear also in clinical journals about return to work among patients who are operated on. And these are 3 very recent papers. The first one is a Norwegian study, return to work after surgery at the neck for cervical radiculopathy. What we see here is the number of patients who work and don't work. The patients who work are green. They receive no medical benefits in Norway. And on the horizontal axis, you see at 0 is the time of surgery. So we can look back 1 year back, and we can look 3 years ahead. And what we see is that 1 year after surgery, 7 out of 10 patients return to work, and this plateaued. So even in the second year or the third year, this number does not increase. And is also quite similar a little bit as before surgery, even if you look at the people who are not working. So the authors concluded also, our results demonstrate that successful surgery alone does not guarantee return to work. A second recent paper is about return to work after surgery at the fingers. People get a small prosthesis in their fingers. It's a relatively small study and performed in the Netherlands. And what this slide showed is the probability of return to work. And probably you all guessed, if you got light work, it's much easier to return to work. Those patients already return to work after 2.5 weeks. Do you have moderate or heavy work? That will prolong the sick leave period to about 12 weeks. 2 factors were prognostic for return to work. Of course, the physical demands of the job, and also the score on the Michigan Hand questionnaire. And that's a self-reported questionnaire about hand function, but also about activities of daily life and how well you are doing in life. The third study is a study performed in Switzerland. It's about shoulder surgery. And you can see here the slide. It's also about returning to work in your previous job. And what we can see is the number of people returning to work in the previous job. And you can see they made a categorization in light, medium, heavy, and very heavy work. And very clearly, there appears to be a dose-response relationship. The harder the work, the less the larger the chance that you do not return to work to your previous job. And also these authors concluded the success of shoulder surgery in terms of return to work is not always complete and varies significantly based on the physical demands of the patient job. Patients with physically demanding work have a significantly higher time to return to work and a job loss rate. So what often, at least surgeon thinks, because often if people don't return to work, they won't see them back in the clinic. Surgery alone appears not to be good enough. So hopefully I have underpinned, I've put some data to for my second note, surgery does not do the trick. So what should we do? And then I like to make a plea for the disease-first approach and include return to work in ergonomic studies. So how can we stimulate work-directed care? And in my opinion, we have to get ergonomics in clinical practice guidelines. So if you do studies, you should try to get your study in a clinical practice guideline. And there are a couple of things that might contribute to get your paper in a clinical practice guideline. Those clinical practice guidelines often start with clinical questions, and it's most often about, is A or B better, in our case, for return to work. So at least we have to get an intervention in which ergonomics is included. And it's most often compared to care as usual. So we have to include ergonomics in the intervention and compare it with care as usual. But maybe more important are the P and the O, the population and the outcome. If these searches are performed for clinical guidelines, you need a disease or disorder or a clinically assessed diagnosis, because all the other studies about pain, discomfort, fatigue, exertion, they are not included. Doctors or other clinicians, they want to say something about a specific patient group, and often these guidelines are disease oriented. It starts with a diagnosis. So if we are performing intervention studies in ergonomics, let's strive to include a disease or disorder. Otherwise, we won't be found or won't be included for the background questions to base the evidence-based decisions on. And what recently is going on, at least in the orthopedic literature, is that patient-reported outcome measures, they aren't that robust. Often people use the outcome measures, maybe validated in one population, used in a similar population, but not very good validated. So Kroksgaard and colleagues did a plea. We have to use clinical outcomes with more robust measurement properties. And luckily, they also say, well, return to work is such a robust outcome. And that's an easy one to measure. And if you look at the paper of Ravinskaya, extensive variability of work participation outcomes measured in randomized controlled trials, of course we can do better, but they give good suggestions how we could measure work participation that can be used in RCTs. So my plea is, if we want to get our ergonomics in a clinical treatment guideline, be aware of the disease or disorder, preferably clinically assessed, use work as an outcome measure, and of course get the ergonomics in the E of the intervention and compare it preferably with care as usual. And an example is this Dutch guideline on low back pain and lumbosacral radiculopathy. And you won't be amazed that the studies I just presented are also included in this guideline. So information and advice in case of sick leave, inventory of barriers for work participation, and what my favorite all-time study in occupational health showed, you have to do something about the workplace, preferably the level or intensity or task or duration. And of course, there should be a management plan around that. So, what's good to hear is that, yes, Erwin Spekley, you can ask Erwin, I think in hopefully 3 years, whether this clinical practice guideline is implemented in the occupational health service Erwin works at, and he's going to perform an evaluation whether or not this clinical guideline implemented in care will actually work to get people more timely at work. So when can they ask you the outcome, Erwin? Is it in 3 years' time or 4?
Yeah, well, the final results in 4 years, but you know, when we're 3 years along, we should know a lot more. Yeah.
Great. Good luck, Erwin.
Thank you.
So that brings me to my last topic. Back at work after surgery. This is about my favorite patient population. And I'll start with a quiz question. What is this? So you can put your answer in the chat and I will ask Erwin to see if anyone gives a good answer. So what is this? What does this slide show? kind of a Jeopardy question. I'll give you the answer. You have to think about what question.
It's a difficult one, Paul.
Okay. I'll give them 10 more seconds. I'll have a look at the chat myself.
Yeah, there are no answers as yet.
No.
Because...
No. Something about knee surgery, and that's very well answered, Michel Regor. This is the expectation in rise in number of knee prostheses worldwide. So what we see is that all around the world, if data are presented, more and more people will get artificial knee. And what I found very striking is, the largest increase in primary surgery is not among the classic arthroplasty population, but among patients of working age. So more and more patients of working age will receive an artificial knee. And the bad news is, return to work isn't that good. It's about the same as in the study I reported on the cervical radiculopathy. About 1 year, 3 in 10 are not working yet. So that's not what we want. So how can we improve that? Of course, I'll make a plea for prevention. A nice Scandinavian study showed that 70% of the hospitalizations is due to 3 factors. First of all, obesity. The second, which is often forgotten, is high work demands. For instance, a lot of lifting, a lot of kneeling. That's the second one. And the third one you all probably know is squatting and or knee injury. So if we can prevent people getting too heavy, if we can reduce the workload, and if we can prevent knee injury, for instance, due to squatting, we can reduce these numbers with about 70%. So that's an incredible amount, which we have to strive for. And there's a lot of attention, at least in the Netherlands, about body weight, and in the rest of the world also. But in my opinion, there's too little attention for the workload as a determinant for end-stage knee osteoarthritis. And by developing the clinical pathway, I like to live up to a saying of Louis van Gaal, the former coach of the Dutch national football team. That's the biggest sports in the Netherlands. And he says, well, quality rules out chance. And that's what we like. We want to rule out chance whether or not people return to work. So how does quality look like in developing such a care pathway? This is what we have come up as one possible intervention. It's in a comic, so we call it the back at work after surgery care pathway. It has proven to be feasible. See the link underneath. Well, as a worker, you visit your orthopedic surgeon. He decides together with you whether or not knee replacement seems efficient to get you, for instance, back at work. And he also, before surgery, refers you to the occupational health physician and also to a physiotherapist. And what quite unique is, an occupational assessor, can be an ergonomist, already goes with the worker to his or her workplace to assess barriers for return to work, and also think about possible workplace adaptations. So that's quite unique, and it's in this way already included in the care pathway, a workplace visit. And of course, the physiotherapist asks you, what is your most important activity at work? This we do with so-called goal attainment scaling. So for this person, I have to be able to climb the stairs while carrying 15 kilograms of weight. So everybody knows this is what we have to strive for after surgery.
Paul, we've got a question from Raffaella Di Benedetto.
Yes.
And the question is, can you suggest a tool for knee risk assessment in workplaces?
Oh, that's a good one. I'm not aware of a tool to assess knee risk at the workplace. But what we can do is what I do. We know from several studies, and I can show the studies, how much time kneeling or squatting or how much lifting gives you an increased risk of getting knee osteoarthritis. So I think this can easily be answered by reviews on this topic. So if you look and I give you a review. So I think it isn't that hard. So there are a couple of reviews that show what kind of exposure in the workplace, for instance, due to kneeling or squatting or lifting, increases your risk of knee osteoarthritis and thereby finally end-stage knee osteoarthritis. So I think this is a very easy question, and maybe if you don't think the worker can give the correct answer, you can also measure it with at the moment, more and more tools are available that give you insight into time kneeling or squatting or lifting. What do you think, Erwin? Is that a satisfying answer? So you don't need a complex tool.
And not surprising to get this answer from you. So well done. But Jordan Rodriguez mentions a tool called LERA, LERA. I'm not familiar with it, but we'll look it up and see.
Yeah, but the same as last, I'm in favor of the disease first approach. There are a lot of ergonomic measurement tools or assessment tools, and I'm always in favor. Has this tool also been validated with real people who really get knee osteoarthritis? And therefore, I refer to this systematic review in which etiologic risk factors in work are assessed, and you get an insight in what really if for the disease accounts for. So not only by expert opinion or workload opinion, but maybe the combination might be very good also to get insights in possible solutions. Yes, do you think I can proceed, Erwin?
Yes, you can.
So after surgery, you have to train. And I think one of the big advantages of this recovery pathway, and it's quite unique, is that the patient gets together with all involved clinical professions. So at week 6, the patient sits around the table, often virtually, with his physiotherapist, with the occupational physician, maybe the physiotherapist from the hospital or the orthopedic surgeon. And after 6 weeks, they'll have a look at how does the recovery go. Do we have to plan for another meeting? Do we have to add extras to secure return to work? So in summary, that's the back at work after surgery clinical pathway. And thereby we hope that people return to work in a more timely manner. And as I said, we performed a feasibility study, and the person on the left is Dick, and specifically for you, he cut off his pants. So you can have a look at his right knee, and he received a unicompartmental prosthesis, half artificial knee at his right knee. And he's a truck driver, 57 years old, works 4 days a week. And in these 4 days, he makes 52 hours. And he has a physically demanding job. He loads animal feed. And to do so, he has to clamber 20 to 30 times per workday on the back of the truck to see if the truck is loaded well, and he has manually to close a valve. And he has, at the different sites where he comes, he has to be able to clamp a 7-kilo hose between his legs and pick up another 7-kilogram weight of the ground. And of course, I'll only share success stories. So after the operation, his workplace was bettered, and not only of Dick, but also of the colleagues. So his boss was amazed, and he did not know that all truck drivers had to climb the truck every working day 20 to 30 times to check the filling and also to manually close the valves. So not only for Dick, but also for his co-workers, this has been improved. And now he can sit in the cabin of the truck, looks at the screen and only has to press a button to close a valve. So I think a nice example of how ergonomics in a clinical pathway, not only good for the patient, but also for his co-workers. Using goal attainment scaling and training, already after 8 weeks, he could clamp 10 kilogram between his legs and pick up another 10 kilograms weight of the ground. His first day of return to work was at 6 weeks and full return to work in 14 weeks. And at the moment, we're evaluating whether this BAS protocol indeed results in a timely return to work and also what the involved costs are. And we asked Dick what he thought of this trajectory, and he said, I thought it was a nice addition. I can't do this on my own. Good guidance. Everyone had the same goal. Sometimes I wanted to go too fast, and then it was nice that there was a quick contact between everyone. I don't really have any points for improvement. So at the moment, we are evaluating this study. Of course, I also asked ChatGPT on the added value of ergonomics, and I'd like to conclude with that. ChatGPT came up with 4 categories why ergonomics is of use in return to work for patients with musculoskeletal disorders who have received surgery or received non-operative treatments. And the first one was a smoother transition back to work. Ergonomic modifications to work environment and equipment can help reduce pain and discomfort, allowing for a smoother transition for back to work. Now, that smoother transition back to work, I hopefully showed you the data that it at least is true for chronic low back pain. And of course, we have to test whether it's also true for people who receive a knee prosthesis. But I gave it a green in the stoplight, so I think ChatGPT might be right. And the second one is in the third category, reduced risk of re-injury. Proper ergonomic design can reduce the risk of re-injury, allowing the patient to return to work safely and continue with their recovery. I'm not aware of studies who actually study this, if patients return to work and were or were not re-injured for musculoskeletal disorders. So that's why I gave it an orange. But it's good to see what kinds of categories ergonomics can contribute to secure a safely time and return to work. So that brings me to my final slides. And foremost, again, thank you all for participating. If you're interested in to receive the slides, you can contact Erwin or Paul Keijer, and you can receive them. And hopefully I managed with these 5 topics to raise more awareness about the added value of ergonomics in securing work participation or return to work after operative and non-operative treatment for workers with musculoskeletal disorders. So thank you all.
Yeah, Paul, thank you very much for a very interesting presentation. The recording will also be posted on the IEA YouTube channel of this session. But Paul, we have some interesting questions. One is from Gunilla Dahlgren, and she asked, do you think the employer should participate? Because in participatory ergonomics, we often see that both the worker and the employee get involved. What are your views on that?
Yeah, preferably yes. Like in the example of Dick, also the employer was informed by the ergonomist about the possible improvements for the return to work process. So that's a very good addition to get the employer involved. Of course, the employer, at least in the Netherlands, cannot take part in a discussion with the clinicians because of all the disease content. But I definitely agree that the employer should be involved, like in the success story about Dick. Not only his truck was improved, but also the trucks of his colleagues were improved. And it's also good to see, because this work-directed care in the Netherlands is not financed. So at least in my hospitals, I have got a surgeon who often writes a letter to the employer of a patient. Well, hello, I'm the orthopedic surgeon. I'm going to operate on your colleague, that and that and that. And we think that the additional work-directed care should be very useful for your patients, so that not only the surgery, but also the additional workplace visit, additional care is of use to get a safe return to work. And then the orthopedic surgeon always says, yeah, unfortunately, these costs are not granted in our social security benefit system, but also does a plea for the employer to pay extra fee to secure this work-directed care. So
Well,
the
that's a
employer
nice
also
bridge.
this way is involved. Yeah.
Okay, that's a nice bridge to a question from David Rampel. And he asks, what are barriers to getting ergonomics added to practice guidelines?
Yeah, I think, again, to ergonomics, to practice guidelines, clinical practice guidelines.
Yeah, what are the barriers to getting ergonomics added to practice guidelines?
Yeah, I think it's what I mentioned on the PICO slide. We have to be more specific in our patient group. If you want to get in a clinical practice guideline, you always have to formulate what's your patient, what's the disease or disorder, preferably clinically assessed. And of course, you have to have a intervention study, preferably in RCT, because those are most often included, in which you incorporate ergonomics and whatever and compare it to care as usual. And I think more and more, at least in the Netherlands, in all clinical guidelines, they have to address the topic of return to work. So that should be one of the outcomes. But I don't know if David's got any other ideas himself, what the answer was to his question.
Well, first I want you to answer some other questions. Another one from Gunilla. What is in your experience the acceptability of this perspective of medical staff, hospital, primary care, doctors, physiotherapists, etc., as part of the implementation? So the question is about acceptability.
Yeah, I hope that by showing the 3 examples, if I understood your question correctly, that clinicians are more and more aware that not only the disappearance of a symptom or the disease has gone, that's not what patients are looking for. Patients want to participate. Patients want to get back at work. That is why they most often do those kinds of surgeries. So at least in the Netherlands, work is seen as a more and more important outcome, also for surgery. And again, the 3 studies I showed, they were all studies performed by clinicians, reported in non-ergonomic journals, but in the clinical journals. So I think, but maybe my glasses are always pink. Maybe I have a too sunny view on the world. So I think more and more clinicians are aware that surgery does not do the trick, and they have to work with other experts to secure return to work. And you could also see it in the conclusions of those papers. And of course, they are often not aware what should be done, so we can add that.
Okay, one last question is from Dr. Arun Vijay. How to increase awareness among employees about ergonomics of the workplace?
That's a broad question.
Yeah.
A safe answer is I already focus on workers who also got a disease and who feel the need to visit a physician or a clinician. And I think that's an important job of in the consulting room to address the topic of the contribution of work to the onset of maybe a certain disease or disorder. You know, the first Dutch slide had people who are in the opinion that their disorder is partly caused by work. They have more sick leave days. So I think clinicians could play a very important role to address the topic of work. And also a lot of patients. I know a study from England in which people with musculoskeletal disorders visit their family physician, and they were amazed that a great number of family physicians didn't even raise the question about the work-relatedness of the musculoskeletal disease or disorder. But of course, this is only an answer for a small group, people who seek care for their musculoskeletal disease or disorder.
Okay, thank you. I got a message that there are two more questions. One is, would you please let us know in writing who to email to receive the slides? We will.
Yeah, I skip through the slides, and on the first one is my, you get a
and I do not
recap.
know what, yeah, I do not know what the, oh, yes.
That's my email. So if you want to receive the slides, send me an email, and I'll send it to you because of the with file sender.
Excellent. And there's one other question from Moon Mukar Poiser. How is light work versus medium heavy work defined or quantified?
Yeah. Thank you for asking. That depends. Sometimes it's just based on self-reports of the employee. Sometimes it's based on the job description. Sometimes it's based on an exposure matrix, job exposure matrices. So that very much depends on the study performed, and it's, I think, mostly based on self-reports in those studies. So we can also improve on that by using more assessment methods to classify those jobs.
Okay, excellent. Let's see, there's a message from Paul. There are published work level guidelines that practitioners can use with defined work classifications. Yeah, okay.
Great.
Are there any other questions? Because if not, then we are going to close this session. I'm having an eye on the Q&A. I do not see any new questions. I want to thank all participants on behalf of the IEA. I see Maggie Graf is also present here on behalf of Steve Fisher, Paul Keijer, and myself. We thought it was a very nice session. We had well over 30 participants, so we're very pleased with that, and thank you for your attention.